Right. Aloha, everyone. We're starting to get everyone signed in here. This is the second of our series of virtual crew trainings. I'm Lehua, and I'm going to turn off my video now and quietly slip away and allow our medical team, who is ready to go here, get started with a very awesome presentation. So maybe I'll just wait another minute while everyone hops online, and then we'll go ahead and get started. All right, I think we've got a good amount of folks on. I'm going to go ahead and turn the time over to Dr. Tamura to kick us off for today. So Dr. Tamura, if you want to go ahead, you can get your screen up and running. All right, looks all good. And we've got just about 90 folks online now. So I think maybe we'll just go ahead and get started. Dr. Ben Tamura, who's been the lead for a lot of our medical related everything basically for many, many years now, has been a past crew member on the voyage, will start us off today and I think introduce the other members of our medical team who are really, really excited. And we've mastered all of our Zoom technical difficulties. So maybe Dr. Ben, I'm going to turn it over to you.
Invitation to do this. I'll maybe start out with introductions. You know, my name is Ben Tamura. I was born and raised in Kamaki, still here. I'm a physician in internal medicine, and I've been volunteering with the Voyaging Society since '91. I sailed with them first in '92, and I've been helping them out with medical logistics for all voyages since. Usually includes figuring out medical supplies, crew clearance, and medical support at sea and on land. We also have helping us today Dr. Kelly Tamsing. He's an emergency room doctor and has been neck deep in this coronavirus thing from day one. He was medical officer on the worldwide voyage Brazil to the Virgin Islands. We're going to have Dr. Marjorie participating as well. She's been helping the Voyaging Society since Kuholo Mau back in 2007. She was on Hokulea when it went to Sadawal, and she's been a key member of our med logistics group when we started planning for Malama Honua. She was a medical officer on the Tahiti to Rarotonga leg, and again when the canoes went to Raiatea on the way back home. She's an internist who specializes in endocrinology and metabolism and is the emeritus and founding chair of the Department of Native Hawaiian Health at the med school. And finally, we have Dr. Seren Tokumura. She's been volunteering with PVS from the beginning of the worldwide voyage and specializes in family medicine. She was a medical officer on the Hawaii to San Francisco leg in 2018.
Hey, Dr. Tamura, sorry, I'm just going to cut in real quick here and double check if you have a screen share. It's not sharing right now.
Oh, okay.
Sorry, I think you did have a slide, that's why.
Oh yeah, no, I didn't. I took it down because Kelly's going to start showing slides.
Okay, sorry, there you go.
So we'll just look at the letter L for now. So anyway, you know, thank you for inviting us to talk today. We were asked to address health and safety issues as a core value relative to voyaging. You know, to talk about practical as well as idealistic issues at sea and on land, here at home, or while away at a destination, personal, family, and community issues as relates to voyaging. Coming out of this coronavirus lockdown, crew training in dry dock sometime in the near future is going to be the first steps we take in getting back on track from where the Voyaging Society left off in March. But as we go through today's presentation, please don't listen with a short-term view of only moving on to dry dock. Listen today through a broader lens of voyaging. You know, the health and safety of our crew, our volunteers, your family, and our communities. You know, starting back up on dry dock is sort of like grabbing the refrigerator, grabbing the handle of a refrigerator. Yeah, there's way more inside. So this is just the beginnings. Now, before I go any further, there was a handout linked to today's invitation to the webinar, and there's supposed to be a disclosure that comes with that. So I'm going to pass the floor briefly to Dr. Marjorie to sort of explain that. Mark, do you mind?
Sure. Aloha, everybody. This is Marjorie Mao. I believe a 2-page flyer went out prior to our talk today, and it's a beautifully done flyer with Olelo no Eao and a bit of a cultural historical background on how to deal with epidemics in Hawaii, which has happened in the past. And it gives you some practical information also about how to make a mask and how to social distance and so on. And this was not created by my colleagues here today on this talk. This was created by a number of people over at University of Hawaii, Manoa. And I was given permission by Dr. Alika Mauna Kea, who is the only native Hawaiian epigeneticist in Hawaii, maybe the whole world, I'm not sure. He has agreed to share it with everybody. And I think the information is really solid, and just wanted to make sure that everyone got it.
Mahalo Kauka and Dr. Tamura. Just in case people didn't get that or they didn't get the email, you should have gotten a link to the website where we're hosting these sessions, and there is another link right there so you can see this handout and flyer. Mahalo.
Okay, so this is Ben Tamura. Sorry, my video camera's not working. Well, to be honest with you, I don't have one. So I'm gonna sort of talk audio and show slides later on when my part comes along. So as an introduction to this talk, there's a reason why we suggested to the Voyaging Society that they address this coronavirus topic up front. So even though many of you are probably sick and tired about hearing about the coronavirus, and even though I have this image in my head of someone in the audience playing an imaginary violin, there is no denying that this virus is a game changer. It's been profoundly disruptive, and we're only a few months into it. And there's much more about it that we don't understand. It's way too early to say, but it's probable that this pandemic virus is probably going to change the logistics of the way we voyage. We have to adapt. If we don't figure out how to adapt and move forward safely, then the mission of the Voyaging Society will cease. And that adaptation starts with understanding what we're dealing with. You know, health and safety has always been paramount for the Voyaging Society. I have, and I know many of you have heard it explicitly said, our first priority at sea is life and limb. Everybody makes it back home in one piece. And on the canoe, as on land, everybody matters. If one person gets ill or injured at sea, the safety of the entire crew is jeopardized. If one person gets ill or injured at sea, the integrity of the canoe is put at risk. The definition of everyone includes not only you as an individual crew member, but your families. Your health and safety must be relevant to your families. So why do we think this coronavirus disruption needs to be emphasized in the setting of a health and safety discussion? Because of misinformation, the scale, the scope, the sophistication, and the divisive intention of the misinformation out there is frankly dangerous. Faith is stronger than the truth. Now, I'm not talking about faith in a spiritual or religious sense. I'm talking about faith in terms of what you choose to believe in. If you have faith that 2 + 2 = 22, even if I go through the motions of proving to you with 4 marbles that 2 + 2 = 4, your faith that 2 + 2 = 22 will win over the truth. That's why the world has flat earthers, Holocaust deniers, and moon landing conspiracy theorists. And right up there, standing shoulder to shoulder, just off to the right of the climate change deniers, are the COVID pandemic deniers. Same smell. To paraphrase something I heard on a recent podcast, some of the press and media coverage on this pandemic is, quote, about as helpful as a bucket of warm hamster vomit, unquote. That's just the way the information world is now. Thus, we wanted to spend time reviewing with you what is intended to be a conservative, apolitical, honest, pragmatic, non-technical review of medical and public health information about this pandemic in order to separate out fact from fiction. It's necessary in order for us to align our core values with our actions. Put it another way, it's necessary in order for us to resume voyaging with health and safety in mind. If we don't align, we risk not taking the proper precautions seriously or prematurely letting our guard down and risking somebody getting sick and spreading it to their family. Now, if someone gets sick outside of the Voyaging Society activity, so be it. It may have nothing to do with fault or anything like that, as this virus is now a fact of life. The risk is real. But if someone gets sick because we got careless or there's an outbreak amongst our crew members working on dry dock, then shame on us. So again, we hope we're not giving too much information. We hope this presentation is not too technical. And at the onset of all of this, again, on behalf of Dr. Kelly, Dr. Marjorie, and Dr. Seren, the information we are giving is subject to change. The science is rapidly changing, and none of us are medical virologists or have any specialty expertise in infectious diseases or the epidemiology of pandemics. So the 4 topics we're going to talk about before we go into question and answer. Dr. Kelly Thompson is going to do a review about the virus and cover clinical information. I will talk some about why this lockdown was necessary. Then Dr. Marjorie is going to talk about how Hawaii is planning on opening back up, as well as some information about how this virus is affecting Polynesians and Pacific Islanders. And then finally, Dr. Seren is going to discuss how we possibly might proceed on to dry dock and resume crew training. So if you have questions, please send them in to the Q&A link, and we'll hope to try and get to most of them. Again, we've not rehearsed what it is we're talking about today, so we're not sure how this is going to go, but we're pretty certain we'll get done by the 6 o'clock end time. So with that, I'm going to pass the floor to Dr. Kelly Thompson, and he's going to talk about clinical issues regarding this virus. Kelly?
Okay, hold on. I'm going to try and share my screen here. And hold on. Okay, so I was asked to just talk a little bit about the virus. I am obviously not I'm an ER physician, but I'm not an expert on COVID-19. I have some experience with it, and by some experience, I mean, I've seen a couple of patients, but by no means do I have the experience that clinicians in Seattle or New York or Louisiana have. However, I don't think that's necessary for what we're trying to do today, which is just a simple review of the virus, so that we kind of have a base as to know what we're talking about when we go forward with recommendations. So first off, the virus, the name of the virus is SARS-CoV-2, or the 2019 novel coronavirus. We're not calling it the Wuhan virus. In the past, we have named viruses for the area or place of the first outbreak, but that has its own problems and sometimes it's not accurate, and going forward, we probably will not do this. COVID-19 is actually the name of the infection, and it stands for Coronavirus Disease 2019. So the name of the actual virus is SARS-CoV-2, and the name of the disease is COVID-19, similar to how HIV is the name of the virus and AIDS is the name of the disease. The coronavirus is a single-stranded RNA virus. It's most likely zoonotic, which means it probably came from other animals. We think it came from bats. We're not 100% sure. Most likely it hitched a ride on another animal before jumping to us. But now it's spread human to human. It can last hours on different objects. And we can pick it up by touching the things and then touching our mouth or touching our face or even touching our eyes. And then the virus, basically the viral particles can get into our mucus system or lung or respiratory system. Let's go. So this is a picture of the virus. You can just, I'm sure we've seen it a lot on TV or not, but one thing to note is the little spike proteins, the little purple guys, though that's basically, and under a microscope, it looks like a crown, which is why it's called the coronavirus. Corona means crown. So this slide basically shows that the coronavirus, there's 7 types of coronaviruses that can affect human. The first 4, well, the first 2 at the top there are the common cold. They've been with us for a long time. And then since the turn of the century, there's actually been 5 other new coronaviruses. And this just goes to show that there's different coronaviruses out there. The one we're talking about is COVID-19. The 2002 one, SARS-CoV, that's another big one, if you remember the SARS epidemic. And then the MERS epidemic in Saudi Arabia, MERS standing for Middle Eastern Respiratory Syndrome. That was another big one. Okay, so this slide just basically shows the different animals that can get coronaviruses. And the one down here on the bottom right is the bat, which most likely is where this virus is from. Okay, a little bit about the epidemiology. I'm sure you've heard the word, the R naught symbol being seen before, or the reproductive number. That's the R with the subscript 0. That basically just means like how infective a disease is. So COVID-19 has an R naught of either as 2 to 4, 2 up to 4, basically means for every person that gets the virus, they can pass it on, or they will pass it on to 2 to 4 people. If the R naught is greater than 2, essentially you can get exponential growth. What we want to do is obviously get that number to less than 1, because eventually then it will die out. Interesting thing about this slide is, look at the top there, is measles has a R naught of up to 18, which means it's very, very infective. I was in a tropical med course once, and the instructor used to talk about how M is for misery, and the first 2 M's were malnutrition and malaria, but the third M was measles, which just goes to show how bad that disease is. And in Western society, we don't know how bad it is, or we rarely know how bad it is, because we're so good at vaccinating our people. But in developing countries where they're not as good, it's a real problem. So that's my vaccine soapbox I'm beyond. Anyway. Next one, okay. So a little bit of the timeline about the virus. First case was noted probably in late November in Wuhan. China notified the World Health Organization in December 31st, just on the New Year's. The first case in the US was in Seattle on January 15th. And then the WHO declared a pandemic in March 11th. And the next day we declared a national emergency. In Hawaii, our stay-at-home order was declared on March 25th, 2020. And the world has changed a lot in the last 6 weeks. Okay, so this slide just shows, this was actually from a couple of days ago, and it shows the number of global cases that have actually been confirmed, 3.3 million, and 82,000 actually in the last 24 hours. and then the number of deaths, 238,000, and the number of new deaths in the last 24 hours, sorry. So on the bottom here, it just shows the number of cases in Hawaii. We've had 600 cases and 17 deaths. We're actually doing pretty good, right? And we can see that by just, most people don't know somebody who's had the disease or has COVID, and most likely definitely doesn't know anybody who's passed away from it. So that's good. That's good on us, right? We're doing a good job. But we have to continue to do a good job because these numbers at the top here, those are real numbers, and we don't want those numbers to become our numbers. Okay, so a little bit about the presentation, the incubation time, which is basically the time from contact to symptoms, 2 to 14 days, most likely 5 days. So 5 days from the time you have contact with the disease or catch the virus to when you start showing symptoms. Some of the most common symptoms you're going to feel is fever, cough, fatigue, and body aches. Most people who have symptoms are going to get fever. Not everybody, but the vast majority will. And then some of the less common side effects. If it gets worse, you're going to get shortness of breath. You can get sore throat, loss of appetite, diarrhea. So GI symptoms are some of the less common symptoms, but in China, in Wuhan, when it first broke out, there was lots of people. Apparently, they saw a lot of people with the GI symptoms, a lot of diarrhea. They didn't recognize that it was part of the COVID-19 syndrome, but later on, when they went and looked back, they saw that it actually was a big part of it. And then one of the other interesting things that people get are loss of taste and smell. That's not permanent though. I did take care of one patient that talked about this and she regained that. Okay, who gets sick? So anybody can get sick, but the risk factors for getting sick are age, greater than 65, race, that is fluid, but we're definitely seeing a lot of African Americans, well, not in Hawaii, but in the United States. We don't know how that's gonna play with our native population here, and native Hawaiians or native Polynesians, but it's something we need to keep an eye on. Diabetics are at risk, anybody with a chronic lung disease, and anybody who smokes. Men are more at risk than women. That may be genetic. They've talked about how a lot of the immune system is noted on the X gene, and women have 2 and men only have 1. But it could be that more men smoke, and it could be that apparently, according to some studies, men don't wash their hands that much. Heart disease, obesity, immunosuppression. People in nursing homes have an issue that might be related to age, and also women that are pregnant. That most likely has to do with their decreased immune system while they're pregnant. Okay, what happens to you when you get really sick? So this is most likely how the virus works. You touch it on you either through contact or somehow you touch it, you put it in your mouth accidentally, it gets into your respiratory system, and then it starts to attack the different cells in your lungs and in your mucous membranes. When it's there, it basically it's a virus, right? So viruses are different organisms than almost anything else in the world. They are technically not living, but they're really good at reproducing itself. All it consists of is some genetic material surrounded by a protein coat, as opposed to like bacteria, which actually is a lot more complicated and can survive on its own out in the wild. Viruses cannot survive on their own. They need a host. So when you get the virus, you get it into your mucous membrane, it gets into your cells, and then it turns your cells into a virus-making factory. Okay, your body sees this and then starts to attack it. And in this war, you end up getting damage to the different cells of your body. So initially, you'll get damage to your lung cells, and it will create a pneumonia. You'll get a pneumonia from it, essentially an infection in your lung. Up to 15% of the people that get it will get a pneumonia, and up to 5% of those pneumonias can be critical. Critical meaning that they may need to be placed on an intubated and put on a ventilator and placed on life support. Other things it can do is it can cause myocardial infarctions or heart attacks, most likely related to direct damage to the blood vessels, to your blood vessels of the heart. And it can also cause what is called myocarditis, or a specific or inflammatory reaction of your, specifically of your heart muscle, which can be related to direct effects of the virus basically attacking your heart muscle. We are seeing strokes in people with COVID-19, and most likely that's also due to damage to blood vessels in the heart. For some reason, this virus likes to attack blood vessels. And we see liver and kidney injury, possibly related to direct injury to the blood vessels, but also possibly related to injury to the directly to the tissue. Sorry. Okay. So this slide. So more importantly, what happens when you don't get sick? Well, when you don't get sick, this is actually a real problem, because you don't know you're sick and you're walking out there in society and you're asymptomatic, and then you can give it to other people, right? Up to 50% of the cases may be asymptomatic, and up to 80% of the cases are people are just mild or have mild disease. So they might have the sniffles, maybe a little bit of cough. They don't realize they have it, and then they can spread it to everybody else. So this slide just basically shows looking at the age of people that tend to get it. You can see how the green bar is basically the number of cases. So the cases of everybody over 40 actually is pretty static, but the deaths are a lot higher in the older population. Okay, so treatment. So treatment is mostly supportive. If you get a pneumonia and you can't breathe, and you can't oxygenate, we put you on a ventilator or we give you oxygen. If you're not that sick and you just have body aches, you get Tylenol. We try to keep everybody hydrated. So most of the treatment is supportive because we don't have medicines for it. However, a few days ago, they did approve a medication called remdesivir. It interferes with viral replication. It's the study that they approved it on showed that it shortened the course of the disease by just a few days, actually. And it's not a magic bullet. It definitely has effects on the virus, but it's not a cure-all. All other medications that you've heard of are still in trials, and most of them has either been proved to be ineffective or we don't know if they're going to work yet. So if we don't have any medications for it, what else can we do? Well, we can create a vaccine for it. Unfortunately, that's probably going to take a while. We do have multiple vaccines that are in clinical trials, but nothing's been approved yet, and probably won't be approved for at least a year. So we can do something else. We can try for herd immunity. However, going for herd immunity means that a lot more people are going to get it, and some people are going to die. So we may want to go for that. That's what Sweden's going for, but I don't know. That's a decision. I don't know if I want to make that decision. And it's also unclear if getting it's actually going to give you immunity. So if getting the disease does not give you immunity, then all those deaths trying for herd immunity are going to be basically wasted. So what the other thing we can try to do is just not get the disease, right? So how do we not get the disease? Well, some of my colleagues hopefully we're gonna talk about that going forward a little bit. So that's COVID-19.
Okay.
Yeah, and I don't know how to stop sharing. Thanks. Thank you.
Okay, this is Ben. Tamura. I'm going to try and share my screen. Okay. So I'm going to cover why was this lockdown necessary. Now, my part's going to be mostly public health. And the hope is that it helps to frame why we need to be careful moving forward as we prepare to resume voyaging. I'll address what I consider to be misinformation that downplays the danger of this viral pandemic and thus risks sabotaging the advice of public health experts who know best. But first, some basic definition and concepts. You hear the word epidemic. What is an epidemic? Epidemic is a disease outbreak that affects large numbers of people but is contained to a geographic area. Example, during the worldwide voyage, our crews went through 3 epidemics. Dengue and chikungunya in the South Pacific, as we were going east to west, and Zika in South and Central America. We bypassed a little epidemic in Madagascar. They were having issues with polio and decided not to go there. Now, these were not pandemics because they were limited to the tropics. They did not spread worldwide. So what is a pandemic? Pandemic is an epidemic that travels worldwide. It's usually a type of contagious infection that is new or novel. So there's no pre-existing immunity, no effective treatment against it, and it spreads very rapidly. Example, the great influenza pandemic of 1918, misnamed Spanish flu. It started in Kansas. It killed 50 million people worldwide. Some estimates are as high as 100 million. There's the Black Death, the bubonic plague in the Middle Ages. That killed 200 million people worldwide. Now, the number of deaths doesn't define a pandemic. It's the ease with which it spreads. Next, you might hear the term endemic. This means that a disease is limited to and has a constant geographic presence. Example, malaria in parts of Africa, Asia, Central and South America. Dengue is now considered endemic in the Society Islands. Leptospirosis is endemic in Hawaii. It's always there, lurking in the background, and you can catch it all year round. Dr. Kelly just talked about herd immunity. It's also called population immunity, community immunity. It's when a population has a high proportion of individuals that are immune to the disease, either through having been infected and surviving or getting vaccinated. This prevents spread to susceptible individuals in the herd, and the infection fades. So finally, some public health concepts about intervening on epidemics. This is relevant to why the lockdown was necessary and why COVID-19 is now a pandemic. And you've probably heard the terms containment and mitigation. Containment is 2 parts: identify and isolate. Identify the active cases so you can isolate and quarantine someone, but that's contingent on being able to track and enforce isolation and quarantine. Mitigation is when containment fails and the epidemic is getting out of control. Mitigation involves actions to minimize the spread and damage, which is what we did with flattening the curve and sheltering in place. Now, successful containment requires certain biological and societal features. If those features are not there, it turns into a pandemic. Containment requires the ability to identify cases efficiently and accurately, which means you have to have a way to diagnose the infection. And that usually means availability of testing. And as you all know, that wasn't there. Alternatively, you need symptoms that are stereotypic and specific and thus predictive of the disease, so you don't need a test, like smallpox. But again, this virus is not like that. Containment also needs a disease with a very short incubation period and a severe symptoms when it starts up, so that infected people get sick quickly and you can find them right away. That way, infected people are not roaming around the community spreading it. And ideally, for successful containment, the disease should lack an asymptomatic spreader state. So you're not trying to find the invisible spreader out there who's infecting others. The second part of containment, the capacity to isolate and quarantine people, requires a societal investment in a public health infrastructure that is capable of rapidly expanding and enforcing quarantine. That takes political will in terms of funding and logistics for tracking and enforcing quarantine. Sometimes that enforcement has to get heavy-handed for the benefit of the many. Now, this coronavirus infection has biological features and has come to life under political circumstances that allow it to flourish and evade containment. Biologically, it's highly contagious, it spreads through the air, it's got a long incubation period, so it can roam far and wide. It has a commonly occurring asymptomatic spreader state. Again, Dr. Kelly said up to 50% of cases are asymptomatic, and everyone who gets sick spreads the virus early in the course of their illness before they become sick. Now, the lack of symptom severity when it starts means patients don't self-isolate, they don't seek care, and infected people are going to work and socializing. The virus also has non-specific symptoms that may mimic many other commonly occurring benign ailments, which means you have to have a diagnostic test. And as you all know, we don't. We do, but it's not readily available. Politically, most of the Western world was not ready for this with testing. And most of the Western world did not have an emergency public health response ready to go. Now, that's not the case in Asia, because Asia went through SARS in 2003, which is why Taiwan, Hong Kong, South Korea, those places all jumped on this as soon as it came out. The West hasn't gone through that, so we were unprepared. Early on in the beginnings of this pandemic, you might recall the battle cry to flatten the curve coming from public health and infectious disease experts. Now, at the same time, a contrary viewpoint was being argued for letting nature take its course and pursuing herd immunity. The United Kingdom started out that way. So we had one side saying we have to be careful and get ready, while the other side was saying it's not a big deal, you guys are all overreacting. The push for mitigation based in flattening the curve was based in historic lessons of the past. The weakest links, the weakest systems that fail under the pressure of a pandemic are usually the weakest supply chains. And healthcare is at the top of the weakling list when it comes to a fragile supply chain that's easy to break. Other things like food, energy, communication, waterworks, etc., they have a slightly greater means of internal control, while the supply chain for the US and Western healthcare system has largely been outsourced to the third world and relocated outside of those countries. The American medical supply chain is now based offshore in India, China, Malaysia, Indonesia, and Italy, with only corporate headquarters and distributors in the United States. So supplies for the American healthcare system is like toilet paper in Hawaii. It's a bellwether for running out of stuff when the setting is in a natural catastrophe. So why is flattening the curve, why does flattening the curve prevent the surge of COVID-19 patients from overwhelming the healthcare system? Again, many said, and some are still saying, that coronavirus was only a theoretical risk. Some even called it a hoax. Now, Italy and Spain were unfortunate examples of how real this risk was. They were at the forefront of this epidemic entering the West. They did not know much about the virus, and they did not have time to flatten the curve. Thus, their healthcare systems had a surge of illness in a short period of time that quickly overwhelmed their capacity and resulted in an excess number of deaths of people dying beyond what the biology of disease would have predicted. Italy at one point had to ration ICU beds and ventilators. Their hospitals had to apply wartime military triage principles to decide who was given the chance to live versus who was set aside and given comfort care to die. Living patients already on ventilators were taken off of ventilaters to give someone with a better chance of survival a chance. Now, that's controversial and difficult, but it's not an evil concept. All the hospitals in the state have been planning for that for the last 2 months. It's not about saving the most lives, it's about saving the most with what you have. And as a society, we don't want to go there. That's the big deal about flattening the curve to prevent the surge from overwhelming the system. I'm sure you guys have all seen this curve before. It's the visual representation of flattening the curve. This is mitigation visualized. That faint blue line going across the screen, that's the capacity of the healthcare system. The yellow curve is natural herd immunity. The purple curve is mitigation. That's the lockdown we're going through. That's sheltering in place to help suppress and spread the disease out over time so that the healthcare system does not get overwhelmed. Now, very important concept, mitigation is not a solution. The goal of mitigation is to buy time to figure out a solution. Hopefully someone makes a vaccine to interrupt contagion, or they find effective antiviral meds to treat the disease so it doesn't kill and infected patients can instead survive to develop immunity or learn to live with the infection. That's the way AIDS was treated. We don't have a vaccine, but we have effective meds to suppress the infection, and people with AIDS go on to live a long and happy life. Either way, the chain of contagion eventually burns itself out with vaccines or antiviral meds. Worst case, we find no vaccine, we have no new treatments. Then the disease goes through a long, drawn-out herd immunity process and eventually fades or it becomes endemic. Just the way syphilis is now considered endemic worldwide. Now, you have all been living the elements of sheltering in place, flattening the curve. You guys all know the drill. Travel only for essential purposes, physical distancing, no large gatherings, wear masks in public, wash your hands, don't touch your face, wash your hands again, protect the vulnerable. It's disruptive, but it does work. And this slide proves that. This is the number of cases that were reported in the 1918 Spanish flu, and it compares Philadelphia to St. Louis. St. Louis sheltered in place. Philadelphia did not. They had a parade to raise money. Political thing. So this is not a new concept. Sheltering in place mitigation is not some liberal left-wing conspiracy to influence the next election. It is a public health intervention that is literally older than sliced bread. And here's a more recent graph showing that it works. This slide shows the total number of test-proven cases of COVID-19 in Hawaii. Never mind how high it goes, pay attention to the slope of the curve. Flat means there's no new cases. You see New York at the top, everything else there is the 49 other states. Mitigation worked. We have successfully minimized the spread, and the potential for a medical disaster has been avoided. We literally have dodged a bullet. If things were not so strict and air travel stayed open to accommodate tourists, I wonder what this curve might have done. Granted, the success is only temporary, and it is true. If a vaccine or treatment is not found, if things don't start to open back up, the economic consequences could be worse than the disease. We'll just have to wait and see. This slide shows what happened in 1918, the pandemic Spanish flu. There were no vaccines back then. There was no antiviral treatment, so there was no choice except to mitigate, retreat, and try to control the rate of spread until herd immunity was achieved. Worldwide, there were 50 million people that died. Some estimates go as high as 100 million in the span of 2 years. Now, it's been said that history doesn't repeat itself, but it frequently rhymes. It's also been said that history has taught us that history doesn't teach us. This slide shows what happened in the United States in 1918. There were 3 waves of infections over 2 years. The first wave started in late spring, starting in Kansas. Infections then quieted down during the summer, and the virus came back in the fall as a second wave, and that's where it did far more damage than the first wave. It then sort of backed off. There were big political fights about the economy, et cetera. Things opened back up. And again, a third wave came on the late spring the next year. And even that late wave was still 2 times worse than the first wave. We'll see what happens if things open up. You know, this is one of the many reasons we collectively want to be careful moving forward. So what about statements like, the coronavirus is just a bad cold. It's milder than seasonal flu. You're overreacting. Let it run its course and go after natural herd immunity. That belief plays off the fact that most people infected do have a mild and benign course. So that's spinning the truth. This argument is getting more and more traction and fueling protests as the lockdown is interpreted as an overreaction across the country. Now, most public health experts across the world advise that the pursuit of passive herd immunity is not the better option. Most experts have supported a mitigation strategy. The pursuit of herd immunity risks large numbers of avoidable death, and if that happens, economic catastrophe will follow anyway. Granted, mitigation contributes to the economic catastrophe, but if science can come up with a vaccine or treatment, we will have avoided an excess number of deaths. Now, there is a real-life public health experiment going on there in Scandinavia. Sweden has chosen the path of herd immunity. And now they didn't do this carelessly. They talked about it. Sweden guys are smart. The World Health Organization is based that. But its neighbors, Denmark, Norway, and Finland have not. And you see the differences in the number of dead citizens there. You see the number of cases, and you see the number of deaths. The parentheses are the case fatality rate. Now, Stockholm is said to be on the verge of achieving herd immunity by the end of this month. And they have not shut down during this outbreak. Their economy is still open. Their schools are open. Granted, they've taken precautions, but they are not in a full shutdown. So what's the better strategy? Natural herd immunity or mitigation? Nobody knows for certain. Time will tell. We have to be open-minded and we have to listen to people respectfully. Now, just for contrast's sake, I stuck Taiwan there in the bottom. Now, Taiwan's got 23 million people. That's almost as much as all of Scandinavia added up. But they've been really locked down tight. They went through SARS and they pulled that out of their hat as soon as this thing came out. Look at the number of cases they got. Hawaii's got more cases than they do. They have only 6 deaths since this darn thing started. But they are really locked down tight. We don't know what's going to happen when they open back up. They've also had to suspend a lot of civil liberties to achieve this. Yeah, everybody's got mandatory cell phone tracking. They report out cases in your neighborhood when they're diagnosed. They don't give names, but you know someone 2 blocks away got COVID-19. Now, Japan and Hong Kong have tried to open up, and they had a second wave break up, and they're shut back down. So again, we'll see what happens. We can't take opening back up lightly. So what about claims that this virus is not dangerous because more people die annually during bad flu seasons? So what's the big deal? Countries overreacting. The last global pandemic influenza was in 2009. It was called H1N1 swine flu. Interestingly, that pandemic started in California. We don't call it California flu. It's called the 2009 H1N1 swine flu. Globally, there were 290,000 deaths over the span of 1 year. But globally, in the span of 4 months, there have been 220,000 deaths from COVID-19. Now, 220 deaths in 4 months versus 290 deaths in 12 months. You know, if we give COVID-19 another 8 months worldwide, do you think we're going to beat 290 deaths? Sub-Saharan Africa, India, South America, and Russia are just getting started. You know, then again, maybe they will be spared. Brazil is climbing up, and Russia is like 8th place in the world now. They're shooting up the ladder. So I'm sorry, I disagree. COVID is not less dangerous than a bad flu season. So what about, now that's pandemic severity, pandemic intensity influenza. What about just plain old garden variety seasonal influenza? I've heard large audience media sources named after furry animals repeatedly state that this is no worse off than seasonal flu. And speaking of garden variety, what about the argument that no more people die from garden variety car accidents, cancer, heart disease, even the annual rates of drowning in swimming pools is not is bigger than COVID-19. So what's the big deal? Again, the country's overreacting. Well, why don't we look at the death rate of garden variety deaths from chronic medical diseases and accidents in the USA together with deaths from seasonal flu and compare that to what's happening with COVID-19. Here's a table with the average annual death rates in the US for a couple of common diseases, including seasonal flu at the bottom there. Now, these are average annual numbers of deaths. As you can see, the attributed deaths to COVID-19 in the US as of May 3rd is 68,000. Today it's 72,000, just 2 days later. Now, compare that 68,000 in 9 weeks to the 2018 seasonal flu, 80,000 in 12 months. Compare the seasonal flu of 2019, that's only 6 months, 23,000 deaths, to how many deaths from COVID-19 in 9 weeks. In 9 weeks, we've gone 3 times higher than the 2019 seasonal flu deaths in half the time. So COVID-19 is not less dangerous than seasonal flu. As for car accidents, again, accidents, I have their motor vehicle accidents in parentheses. The average annual death rate from car accidents in the US is 40,000. In 9 weeks, we've surpassed that with 68,000. That's just patently false. More people die in car accidents than this COVID-19 virus. Now, as for those other diseases, heart disease, cancer, lung diseases, stroke, other stuff that goes out there, kidney failure, all the other chronic diseases that people end up in the hospital for. There's an important point to be made that's not shown by just looking at absolute numbers of people who die. The US healthcare system is built to accommodate that demand. Cancer, accidents, heart disease, and lung disease, strokes, and all of the other garden variety medical reasons people get admitted to the hospital and are cared for day to day in this country. The healthcare system is not overwhelmed by the volume of these usual medical conditions. It's like the Alawai Canal. The American healthcare system is built to handle usual changes in the tides day to day over the course of the year. But the Alawai Canal cannot manage a Category 3 hurricane storm surge that hits Oahu from the south. The U.S. healthcare system is not built to withstand a storm surge, but it can handle routine, predictable king tides. Again, but not a hurricane storm surge. So this is a very deceptive argument that downplays the seriousness of this coronavirus by comparing annual death rates to numbers from just a few months of time. It's also a disingenuous argument to compare the number of deaths from cancer and heart disease to the number of deaths from coronavirus, because the issue is the surge, not the absolute number and annual numbers of deaths. The surge in acute cases is what breaks hospital capacity, not the numbers spread out over a year. Now, there's also the issue that's come up to the surface that doesn't get mentioned much by COVID deniers, the fact that caring for usual medical conditions does not take out healthcare providers. So caring for heart disease does not give CV ICU nurses heart disease. Caring for cancer patients does not give oncology nurses cancer. Caring for COVID-19 patients, on the other hand, infects healthcare providers. And one report in early April said to date in the US, over 10,000 healthcare workers have gone out. Close to 30 have died from catching COVID-19 from work. Again, it's not accurate to say COVID-19 is less worrisome than cancer, or less worrisome than heart disease or strokes, just because there are far less deaths from those chronic diseases. Viral pandemics overwhelm and break the medical supply chain. Routine chronic medical diseases and accidents do not. Two more points to make about misleading statements about COVID-19 and why this shutdown happened. I've been seeing more and more that the number of deaths from COVID-19 is being overestimated. Now, some media outlets are claiming doctors are trying to make it look worse than it is by blaming a patient's death on COVID-19 when the cause of death was a heart attack or stroke, and the patient just happened to test positive and be in the hospital because of that. Now, you've heard from Dr. Kelly, that's not true. Based on autopsy reports, the number of deaths related to COVID-19 are probably being underestimated, not overestimated. SARS-CoV-2 can directly cause heart attacks, heart failure, intractable cardiac arrhythmias. It can cause seizures. It can cause strokes. It's causing Guillain-Barré. It's causing bringing out Kawasaki's disease in kids. Causes blood clots to the lung. It can harm other organ systems to cause death. COVID-19 is not an innocent bystander in these cases. And finally, an argument that hasn't gotten much press from COVID deniers, and therefore they haven't really had a chance to distort it or report it out as alternative facts. The surge of COVID-19 might actually be increasing other causes of death unrelated to being infected. This is from the New York Times a couple of days ago, and it's good evidence that COVID-19 has contributed to an increase in the death rate for people who are not infected. Now, this was predicted early on by healthcare experts. If you look at this, this shows large U.S. cities that have been hit hard by COVID-19, and there has been an excess number of deaths from chronic medical diseases in patients who are not infected. The gray line is the predicted number of deaths from chronic medical diseases averaged out over the previous 5 years for this time of year. The red lines are the actual numbers of deaths from those diseases in patients not infected with SARS-CoV-2. And as you see, the red line spikes up in mid-March. These patients are not infected. It's hypothesized that in hard-hit cities, the volume of people with COVID that have flooded the emergency room and hospitals and urgent care clinics may be discouraging or interfering with patients seeking medical care for usual things. Patients who are not infected have also been quoted as saying they deferred care or delayed seeking care because they didn't want to bother. Now, these graphs suggest that there's an increased number of deaths from garden variety chronic medical diseases that are not infected, and that is an unanticipated consequence related to the surge in COVID-19 cases. So in summary, there are many sound scientific reasons why this pandemic lockdown was necessary. Yeah, mitigation by flattening the curve was to buy us time with hopes that we'd come up with a vaccine or antiviral treatment. This virus is more contagious, more unpredictable. Containment was doomed to fail from the beginning because we didn't have testing. We have an asymptomatic spreader state, and those mild initial symptoms are very nonspecific. It affects the body in ways that colds and influenza do not. This is not a bad cold. This is not just seasonal flu. Herd immunity results in a lot of people dying, and the consensus of experts is that it's not the better strategy. So please don't compare annual death rates from diseases to death rates happening in just a few months. Don't compare death rates for medical conditions that do not surge and have never been known to overwhelm the healthcare system. This virus has already proven in Italy and Spain that it can break hospitals, and that includes infecting frontline providers. No one has been proven to be deliberately overestimating the death rates from COVID-19, so please stop that fake news. And there may be an additional negative effect from this pandemic in the form of an increased death rate from natural causes linked to COVID-19 causing decreasing access to care. So again, this is a bit long-winded, but again, if you don't know why all of this is happening, why we have to go into lockdown, then you may not respect why we got to be careful coming out of it. No one disputes that the economic harm from this shutdown is serious. That's what the big deal is all about. When and how do we open back up? Science tells us about the virus and the disease, and unfortunately, politics is forcing itself upon us as to how we reopen. Sad to see this happen because it happened in 1918. The medical experts were at war with the political people. I think Congress passed a bill that criminalized things said in the press that went against what politicians said. That was 1918. So medical science does have some wisdom as to how we open up. And with that, I'm going to pass the floor to Dr. Marjorie Mao.
Okay. Can everybody hear me? Okay. Mahalo. So I was given the task of how our state's going to open back up, and more specifically, let's see if I can get this to work. Oop, wrong thing. Thanks. Okay, maybe not. Oh, here we go. How is the state of Hawaii going to open back up? So in my short presentation, because you've heard a lot of good information from Dr. Kelly and Dr. Ben, and you're going to hear more information from Dr. Seren. So hopefully this will be, I think, a re-emphasis and maybe some new information. So I'm going to talk about the guidelines with both federal and state of Hawaii, and what can we do, you and your family, to help PVS get back on track safely. And I guess I didn't put my image up. What is happening in our communities? How can we be supportive? And how can we prepare for whatever happens? So as the other speakers have already mentioned, these are the general CDC guidelines for reopening, reduction in number of new cases over 2 weeks, availability of testing for the virus, SARS-CoV-2, or for antibodies to the virus, and these tests have their issues. I think Dr. Seren's going to go over a little bit of that. the ability to track contacts of identified cases. And this is something that I think, especially in the Taiwan case, was particularly carried out very well. And the reason to track these contacts is for testing or for quarantining for 14 days. I also want to mention that once you identify cases, are there resources for proper isolation of these new cases? Most of the recommendations are saying it should be done at home, and there's information about contacting your healthcare provider. And some of that is changing as we learn more about the different ways that SARS-CoV-2 presents. And then hospitals in Hawaii, and particularly on Oahu, where most of the hospitals are, we've been very fortunate in having the capacity to address these issues. And as Dr. Ben showed, it's because we were able to flatten that curve. So what can we do, you and your family, to get back on track safely? This comes right out of the CDC guidelines about keep learning and how it spreads. I can't overemphasize this idea that whatever we're telling you today will be different in maybe another week or so. As we learn more about how this virus spreads, how it presents, and about new therapies and treatments, what's happening in individuals who have comorbidities that put them at high risk, and how to mitigate that. So new information is available every day. Washing your hands frequently and avoiding touching your face. Apparently, people touch their face about 20 times an hour. So if you touched your face, that's one. The other thing that needs to be done is avoiding close contact. And ideally, that's 6 feet apart. But in some cases, this may be impossible. And I think that's one of the issues in regards to several occupations, as was mentioned about service providers. It's impossible to get your hair cut if you have to be 6 feet apart. Another issue is covering your mouth and nose. I've seen a lot of people with face masks on, very colorful face masks, but it doesn't cover their nose. So covering both your mouth and nose. And remember that covering your mouth and nose is more about preventing the spread in case you are infected. Because up to 50% of individuals who are infected may not have any symptoms at all. And then of course, cover coughs and sneezes with the inside elbow part of your arm. Clean and disinfect. I know on the canoe, we try to do this all the time because we're in close quarters. We usually just clean, but beyond cleaning, there needs to be disinfection. And I put down there on the bottom here, this is from the CDC guidelines on EPA approved disinfectants that are used to clean and disinfect daily high-touch areas. So what is happening in our communities? In the state of Hawaii, as of today, there were 625 cases of COVID-19. 563 were in residence. So most of the cases are in residence, and it's community to community spread. About 12%, 73 individuals required hospitalization, and 551 have since been released from isolation. And there have been 17 deaths. Few hospitalizations have occurred, and that's a good thing, but 28% of the hospitalizations have occurred in individuals over the age of 60. Oops. On the right, I put in here a graph. I apologize if you can't read everything, but this is just showing here in Hawaii with an N of 559, so it's a little bit dated, not totally here on May 5th, but you can see the community exposure in red, the travel associated contact in blue, and travel in darker blue. So you can see way out here in April, it's all about the community to community spread, emphasizing, as Dr. Ben mentioned, our need to social distance. What is happening in our Native Hawaiian and Pacific Islander communities? This information comes from the Department of Health here on the left, showing Native Hawaiian Pacific Islanders, 14% of the cases. 10% is what's listed here as the representation in the state of Hawaii. However, I think some of the Native Hawaiian Pacific Islander individuals and others are in this 2 or more race or ethnic categories here. So we are slightly overrepresented in how many Native Hawaiian Pacific Islanders have COVID-19 compared to our representation in the state's population. And then here are whites and Asian populations, which includes Filipino, Japanese, Chinese, Korean. This is from an article from my colleague Keawe Koholakula and Ray Samoa in California. Ray actually is a physician and also contracted COVID-19. And here you can see the confirmed COVID-19 cases per 100,000 by race in 5 Western states. And you can see that Hawaii actually has a relatively low number of people, despite the fact that we have over 150,000 Native Hawaiian and Pacific Islanders here in the state. So we're doing a good job in keeping it contained here in Hawaii. I wanted to put out here, given all the good information you've been given so far about the virus and why the lockdown was necessary, about where you might be able to find reliable and useful sources of information. So I mentioned here Dr. Alika Mauna Kea and others who created that Native Hawaiian Health COVID-19 flyer. I hope all of you got it. If not, I think Lehua can send it out to everybody. The Centers for Disease Control in the state of Hawaii, I've been on it multiple times in preparation for this talk, and it's a very good source. National news media outlets, Dr. Ben mentioned the New York Times. They are a very reliable source. I subscribe to the New York Times myself. And then I want to recommend, if you have Netflix, this Coronavirus Explained. It's another very nice and not too long explanation, and puts it into context of all the other epidemics and pandemics that we've been through, both in the United States and throughout the world. And it really gives you a good perspective of what's going on. In terms of those of you who are into the scientific news outlets, the Johns Hopkins Public Health Tracking website, and then of course the National Institutes of Health, and in particular Dr. Tony Fauci, who is head of the National Institutes of Allergies and Infectious Diseases. And if you have others that you count on for information, please feel free to share. This is the time where I think all of us who can keep ourselves informed will help to turn the tides, hopefully. So finally, how should we prepare for the time when we reopen? All the information is likely to change without notice. So just know that it's, don't worry too much about it, but we're all learning about this novel coronavirus. What we know is that until we have a vaccine that works and therapies that work on individuals that actually contract the disease, the COVID-19, we must reduce the spread of SARS-CoV-2. And we're doing a good job of that, especially in Hawaii. My own perspectives is, remain calm. There's a lot of chaos out there, and I have to say, I know how to be a physician and an endocrinologist, but I'm not sure I'm that good of a homeschool teacher for my twins. But I try to remain calm, and our kuleana, e Hawaiiao, we're Hawaii. This is our place. And so we have a kuleana, not just to ourselves and our family, but to this place and to, you know, what the mission is of the Voyaging Society. I like to think about learning useful information to inform decisions. And I would highly recommend, nobody can tell you what to do, but if you can gather important information that will help inform your decisions, that's a smart thing to do. And I think also my involvement is really about the keepers and practitioners of our ancestral knowledge. They need protection. And because e Hawaiiao. So this is also a graph here from that Coronavirus Explained episode 1 on Netflix. And it shows you in terms of less deadly, extremely deadly, not contagious, and very contagious. And like Dr. Ben was saying, here's measles way out here. Here's smallpox that we as humans actually eradicated from Earth. And here's Ebola that you might have heard about in other countries. And here's COVID-19. And here's the 1918 flu. So the comparisons and what we have learned from the past to inform what we're doing today is really critical. And then finally, I'm sure all of you guys recognize this. And questions, please send them to our Q&A. And anybody know which Va'akaulua that is? You can chat it or Q&A it. Thank you. Bruce, you look like you know what it is.
Nice picture, Doc. Thank you.
Mm-hmm.
All right. So, thank you guys again for joining us. I'm Dr. Seren Tokumura, and I have the pleasure of trying to explain our medical team's plan to return to dry dock. All right, let's get started. These key points I want you guys to hopefully keep in mind throughout this presentation. The first being that this is our current plan, and it's based on the information and the resources that are currently available to us. And like you've heard every single panelist mention, our information and the resources that are available to us are changing on a daily basis. So with that, we are willing and able and intend to change our plan as new information and new resources become available to us. Our plan will be in lines with risk minimizing, but it is obviously not going to be risk eliminating, to be clear. We're not gonna let ourselves get too far ahead of the state and city and county plans. I think this is what we're all waiting for. So dry dock participation will be by invitation only at this point and will be contingent on completing a medical screening. Crew training will be occurring online from now. And your health is your kuleana. So we're hoping to take this opportunity where people are interested and focused on healthcare to really emphasize the fact that these are core values of PVS itself, and these are health, wellness, and safety are things that we take very seriously, both while voyaging and while we're at home. And we want to make sure that that stays at the forefront of our organization's actions as well. Okay, so dry dock participation by invitation only and contingent on medical screening. So how are we thinking about actually doing this? Well, thankfully we have a couple fearless leaders, Nainoa, Bruce, and Bob, who will be in the process of identifying the individuals who are of high necessity at dry dock and for operations. We've heard this word necessity be thrown around a lot in the last few weeks, months. Necessity means that your physical presence is required in order to accomplish a task, or you are indispensable to accomplishing a task. And again, we're gonna leave that mainly in the hands of leadership to determine who they need around at this point in time. Medical screening will be conducted by Polynesian Voyaging Society doctors and will be very similar to the pre-voyaging interviews that you guys had if you guys participated with any of those. So specifically, we need to get a good handle on you, being your age, your health history, especially with regards to chronic diseases such as diabetes, high blood pressure, heart disease, lung disease, which includes smoking, both present and past. These are important factors for us to take into consideration, and certainly an immunocompromised status. As well as we want to be giving the attention and the diligence to your ohana that they're deserving of. So we need to know what your living situation is, meaning who you live with, their occupations, and their risk of exposure for themselves or of exposing other people, as well as keiki and kupuna that you guys have in the household. And this is a pretty busy slide. So let me try to explain what we're looking at here. These are going to be some of the points that we use in order to determine the relative risk in bringing somebody back to dry dock. So from the personal side, these things will factor into our decision making. There is nothing that should make or break your ability to be present at dry dock, same way there's nothing that should make or break your ability to voyage, but there are things that will make you a better candidate and a worse candidate for the current situation, and we'll talk a little bit more about those things. From the personal side, again, age is certainly something we're taking a look at, as well as diabetes, lung disease, lung compromise, including smoking, heart disease, and the immunocompromised status. Also taking into account other well-controlled chronic medical conditions or other medical issues. And then as far as the exposure side is concerned, we're looking at recent travel or high-risk exposure. So for instance, myself and Kelly working with patients on the daily basis that are coming in with sick symptoms, we certainly would be considered high-risk exposure individuals. Within the household or for the ohana, we're looking at each adult aged greater than 65 years old, that's not yourself. And we need to know if they're incapacitated or medically fragile. Each adult in the household with high contact with others, so their job requires that they are frequently in contact with people, or they're considered an essential worker. And each school-age child. So those are, again, just things that we're going to be weighing in order to sort of help us determine who the least risky potential spreaders would be in coming into dry dock. And then necessity, so that right-handed column, we're leaving up to our admin to basically determine what the scale of necessity is for that individual. If no one else can do it, no one else can do it, and we'll have to sort of try to make accommodations to keep people as safe as possible if that's the case. But there is certainly a scale of necessity. No one else knows how to do it, but very union style, you can stand there and tell them how to do it. That is certainly an option. People who are adept at doing things, and it's about a culture. So if you're really big and strong, you're usually pretty useful. So that buys you a little bit of necessity, or really, really good following directions, works really well with the crew. Those are all sorts of things that we will be taking into account when we're doing our dry dock screening. Please, 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 when we do this screening, it is really important that you guys are honest with us. It's less about you guys and more about these guys, you know? And certainly you don't want to be the guy that knocks off that guy, you know? So these are the reasons why we're asking the questions that we are, and why we need to get a very good gauge on where people actually are as far as their risk factors, so that we can make the best possible decisions for the organization itself. Keeping in mind, as Marge mentioned, that we have a huge obligation to care for the people who are our cultural gatekeepers, so to say. So. All right, at each dry dock session, once we've cleared people to come in, there will be a check-in where we will ask again about symptoms. So things like fever, cough, runny nose, sore throat, diarrhea, nausea, vomiting, body aches, fatigue, headaches, sick symptoms in general. If you're sick, please don't come. Yeah, this is just one of those having a level of social obligation, and again, you don't want to be the guy that knocks off the cultural gatekeeper for navigation. So these are things that we're going to need people to be very honest about. Interval exposure risk, meaning if you've had any exposure potentially between the time when we interviewed you and when you walked through the doors, we'd like to know about that. Temperature checks. Consent. So this is something that we would like our families to be involved with as well. Similar to how we consent people prior to leaving on for voyaging. It's something that we want the family to be involved with as far as decision making is concerned, because that individual, and by extension the family, is certainly at a level of risk. Again, we're attempting to minimize it, but we're certainly not eliminating it entirely. So it is something that we would like to have family weigh in and hopefully approve of you showing up before you show up without anybody's knowledge from back at home. And testing. This is where I'm just gonna touch very briefly on this because to be quite honest, we don't have as solid of a plan for testing as we would like at this point in time. Again, we're gonna have to just admit that we don't have the quantity of formal testing available to the community that we would like to have at this point in time. What we do have, what is available in abundance recently, is point of care antibody testing, which has been given emergency use approval by the FDA. That is actually different from FDA approval. And it's important to note that distinction because when something has not been FDA approved, it hasn't gone through the clinical trials that we're used to a test going through in order to validate it in human beings. At the time, though, that was the best that we had available to us, and so that's the option that we had to go with, mostly because of its availability more than anything else. I believe that there are a handful of tests that have now gained FDA approval on the antibody side. But we do have a small set of these tests, and we will be using them at our discretion, at our physician's discretion, in order to assist with risk stratifying. That's about all I have to say about antibody testing at this time, though. I'm sure there's probably a lot of questions about that. Who's going to be eligible for those things? And there's still things that we're working out within the medical team at this time. When you're actually down at dry dock, we're still going to be practicing these really important concepts that Ben and Marjorie touched on in great detail, doing things like wearing masks. Please bring your own, we're not going to supply masks, but masks at all times while we're around each other, frequent hand washing, and physical distancing. So again, that does become a little bit challenging when we're working in the dry dock situation. So there's going to be certain things, certain projects that we can hopefully do from home. And so we'll have our admins sort of delegate what things can be taken home, what things can be done as solo projects, and we'll probably be doing a lot more of that if we're able to at this point in time. But there's certain times when we can't necessarily dry dock from home, when we have to accomplish things like lashings or actually working on the butta itself. So we're gonna change how that looks a little bit. This is Matatini and Timmy, they're two of my crew members. I don't know what they're doing right now. It looks like something really strenuous. But if this were to have to occur now, it would look slightly different. Don't laugh, I don't have, what is that? I don't know, skills to do picture editing and stuff. But it's gonna look a little bit more like that. So Timmy's still in the picture, he's just in the back now. Rex, that's Rex. But everybody's got masks on. So we're gonna have our guys with a little bit more experience. If they are older, they're gonna be stepping back a lot. And they're gonna be in a much more supervising and advisory role. They're gonna still be giving us the instruction that we need in order to accomplish the tasks that we need to accomplish. But we're gonna leave the task doing to our younger crew, actually, crew that falls into lower risk factor categories. So again, this is another example of when we can't dry dock from home. That's Gary in the corner here. So this would look more like something like this, where we've got, not Gary, we've got somebody like Kalani. I shouldn't be supervising, that'll be someone like Bob, and Pedro probably won't be taking notes over there. If we are required down there, then we're gonna be working because of our lower risk factors. Whereas some of our older guys, oh, and everybody should have masks on. But this will be a lot more of the setup that we'll have if we do need to be working in teams. And again, this is something that we're going to be going through appropriate medical screening, risk stratification, and determination of necessity in order to figure out who is safest to bring back first. Beyond dry dock, we're gonna be moving crew training online for now. So similar to these sorts of sessions, we're gonna have some of our guys create content so that we can continue with our crew training, although we'll be separated at this point. Training on the canoes is to be determined. Timing, voyaging also to be determined right now. That's going to be very dependent on international ports and international maritime law. And until we get a good handle on that, we have to be very cautious about setting sail into the middle of the ocean and not being able to land anywhere. So voyaging is still on hold at this point. Again, information and resources are changing daily. So we'll continue to take the information as it arises and make the best decisions that we can, keeping in the forefront of our minds the well-being of our crew, our families, and our community at large. And again, health, safety, and wellness are core for the PVS crew and their Hanas, both while voyaging and while at home. And it's going to remain our priority moving forward. So yeah, we hope that you'll join us for our upcoming talks and that this is useful for you guys in some capacity. That's all I got from my side.
Okay, this is Ben again. So in closing, and after I sort of give a few words of closing, I wanted to open up comments specifically to leadership, Lehua, Archie, Bruce, and Nainoa, to give any comments before we go to question and answer. We hope this presentation was helpful to you guys. You know, we hope you learned something. Our purpose was to get everybody on the same page as we move forward together. Again, we want to minimize the risk of someone getting sick. We want to help, and we need your help in terms of adapting to how we voyage as we move forward. We hope you leave today with a healthy respect for what's happening, and the ways and why things are the way they are. this the beginning of moving forward is understanding where we are now. So with that, first I'd maybe start out with, is Archie online? Does he have any comments? I don't know. Sort of caught him by surprise with that.
Hey, Ben, sorry, let me try and track down Archie in the meantime.
Okay. Bruce, while we're trying to reach Archie, what's top of mind for you? What do you think? Any comments?
No, I thank you very much. I thought that was well done. All you guys who presented the different perspectives and areas. Just for, just from a wrap up from leadership side, I just want everyone who's been following to understand that you're right, Ben. I mean, at some point in stuff, we've got to separate the wheat from the chaff, or the fact from fiction. I think that one thing from a leadership point of view, we have a great team here, and we have 100% trust and confidence in what you folks, how you folks been caring for us, over the years, over the decades, over the, the tens of thousands, hundreds of thousands of miles, and everything else between that gets us there. So, thank you so much. I want everybody to know that, I mean, as we already know, the seriousness of all of this, but the policies, and so things will change at METC and moving forward. And Seren, you're right. Initially, when everybody to understand, it will be by invitation only. If we miss anybody on the invitation, it's not something that would be purposeful. It'd probably just be something like just a slip of the mind, because there's so much to think about moving forward. But Nainoa and Bob and myself will get together, and we'll just proceed as the best we see. And super appreciative of today's presentation. Thank you.
Thanks, Bruce. Sorry, if I could just be, because I did want to address this. I wanted to make sure that this wasn't anything that would make people feel excluded in any capacity, because it's certainly not our intention. But I do think that at this point in time, while we still have such limited information and resources, we do have to prioritize the health and well-being of individuals like Nainoa, like you yourself, Bruce, like Bob. And we've got to get certain things done, certain tasks done at dry dock. And if you guys have people that you are comfortable working with and that fall into low risk categories for us as far as how we're screening people at the moment, that's what's needed at dry dock. And it's not with the purpose of being exclusionary, it's just with the purpose of getting things done and minimizing risk as much as we possibly can at this point in time. That's all.
Yeah, got it, Doc. I think that's probably how everybody felt, about it.
Mm-hmm.
I mean, what was stated was that we need to proceed with caution.
Yeah.
So we'll just proceed slowly. We'll get the wheels turning. We'll get there. Yeah.
Okay. By any chance, is Archie on? Does he have any comments? If not, Lehua. What's top of mind for you? Any comments?
I think I need to rewatch the whole thing again because you guys had so much information. I'm sure many of our crew are probably like reeling with how much about epidemics and COVID-19, coronavirus, so much great stuff. Sorry, I live in a very loud location, which has been really informative and helpful. Definitely, we have our work cut out for us in trying to figure out how to get back to the task of voyaging at some point, recognizing that a priority is everyone's health and safety, and there are going to be probably even more challenges, economic challenges for many people as well moving forward. So I think we're just kind of, it feels like, you know, day by day, and adjusting as we go, just like voyaging. But I'm really thankful for that. It was probably the most concise, organized information I've heard to date about anything related to this whole situation. So I appreciate that. And I'm sorry, I don't see Archie, and so I'm going to just try and call him now. Okay.
Okay, otherwise, maybe we'll pass it to Nainoa. Do you have any comments? Closing comments?
Am I on? Okay. Well, thank you. I mean, you know, I'm really old, so I kind of saw stuff happen over the years. Hang on a second. And I just want to take a moment to, you know, we had 4 amazing, extraordinary, committed medical doctors on this panel today, but just if we take a look at the, you know, the 45 years of voyaging, and we probably had 50 doctors that have kept us safe. So I just wanted to aloha everybody, all those doctors that are not on the panel today. They all deserve to be there. But we felt that the number 4 was kind of the max. And so I just want to just make sure that we recognize them, and we remind ourselves of how valuable the medical doctors and the commitment that leadership would make to ensure that they be on board to make sure that we all come home. And but at the same time, I look at these 4 doctors, and this is a presentation on leadership. It was, again, I'm old, I'm looking backwards. Hokulea, if you take a look at its legacy and history, it was always confronted with challenges. Every single voyage was a confrontation, a challenge. And it's so important that leadership, when they make a promise to the child of a crew member or the spouse or family member or friends, that we're doing our best. We're doing our best to keep it safe and as the number 1 priority. And we really do mean that. And but you know, again, Hokulea itself, what it does, it takes high risk. It's a high risk organization and a set of practices. And so when we say minimize risk, the doctors really mean it. And so reflective in that presentation was leadership, but also was I sense a deep set of values that's all centered around caring for everybody. That's going to have to move forward in a different world. And you know, of course, we want to be inclusive. Of course, we don't want to leave anybody else. But there's new rules. There has to be new rules for us to keep the promise. And so we are working on it at the advice of our core medical leaders right now, all 4 of them. But we're gonna stick by the rules. And I'm saying that probably if you took a survey of the list of risk factors and match it up against who I am medically, I might be the highest risk. And I get it. And I get it that it's that's the way it needs to be when the blue light of the clear skies come out and we get to go sailing, because it's not going to stop us from sailing. And you know, it's going to be a different world. I don't know my place, and I'm okay. But I do again want to thank the 4, because they are setting the the pathway for us to have the rules and to understand the rules, to understand that this is not about us as individuals, it's about the whole family of voyaging, and the fact that in the risk that we take, one bad incident, one bad day could destroy everything that we do. And so I didn't plan to say much, but I was moved by the presentation, not just by the information, but I know how hard you worked on this to get it forward. And this is only one of 3 health and medical presentations. This Friday is not going to be a health and medical presentation because this team wanted more time to prepare. It's going to be next week, Tuesday. And so this Friday's presentation, Bruce and I will sit down and talk. We haven't had a chance to figure out what to put in its place. But the fact that they want more time means that they want to do it well. And so again, I just want to thank this group for starting to navigate us to this future that we can walk into. And I would argue that this is the best pathway I've seen publicly to talk about emerging out of COVID-19 isolation and stepping into the world that you believe in, and you're willing to take risks for. I think it's the best presentation I've seen. So with that, I turn it back over to you, Ben, but I just want to thank, again, all 4 of you for the leadership and the care for all of us.
All right, thank you. Mahalo. I assume Archie got tied up. So with that, maybe we can move on to question and answers. Now, I noticed there's a little Q&A icon here that I clicked on, and we have a rip-roaring, wow, we got like 5 questions, which is great. This is awesome. I was hoping for 0. So I think we can get through all 5 of these. One was a comment, so we only have 4 questions. So first question, oh, now they're popping up. Stop typing, you guys. So here, first one from Joy Anchetta. Is there any advice for staying safe for those who have family members or partners who are essential workers in the medical field? I think I can answer that. Yeah, most people that are essential workers in the medical field, talk to your colleagues, talk to people that are your peers. There are protocols, there are information sources that address, depending on what you do, how to come to work, what you wear at work, and how you get back home. I saw something online that had to do with the ICU doc, and the guy dressed as with 2 layers of clothes. He goes into the hospital with one, he takes it off. When he's done, he wears protective equipment. When he's done, he takes it off, throws his clothes in a plastic rubbish bag, and goes back to his car with his regular stuff, and he showers outside the garage in a spare room before he goes into the house. I mean, every discipline sort of has its own little routine, and it's probably best that you talk to your peers and don't just wing it, because there are protocols, proven protocols for how your family can stay safe. I hope that answered the question. Another question: will there be ways for those of us who are high medical risk to still contribute to dry dock efforts, either there or from afar? When the time comes, ask. Someone like me, age, etc., I would be in a high risk group. Does that mean if they need help sanding and varnishing donuts, I can bring a bunch home and can prove myself worthy, do 1 or 2, bring it back to inspect, and then they give me 10 to do at home? I mean, yeah, there are ways you can help with dry dock, but that's when the time comes. Still a ways out there. Can't give much more in terms of detail. But yeah, definitely consideration will be given for that. The next question: how will summer temperatures affect the rate of new COVID cases? What about a return in the fall? How can we predict when and how many cases when and how can we predict how many cases the second wave will bring in the fall? I don't think anybody can answer that. There are a bunch of people out there that are coming out with models and putting forth predictions. I put my hat on what Anthony Fauci said, and when he was asked this question, he used deliberately the word inevitable. Now, that's a really powerful word for someone with media experience and administrative and leadership experience for someone like Fauci. For him to say the word inevitable, to me, is really powerful. I hope he's wrong, but I don't know that anyone can really answer how summer temperatures are going to affect this, and if and when will it come back in fall. Most other coronaviruses are seasonal and they do back off in the summer, but then MERS, which is a coronavirus, Middle Eastern respiratory syndrome, I mean, that's endemic year round in 110-degree Sahara. So it comes from camels, that's the reservoir. So again, I don't know that people are sure. This is a unique virus that has surprised the medical world with what it's capable of doing and how it's behaving. Again, not a good answer, but an honest one. I think that's all the questions. The other two were comments.
Hi, this is Marjorie. I also want to acknowledge our other medical officer colleagues and the time and effort that they put into volunteering. There is a lot of expertise around in the voyaging community. It's really kind of an amazing thing, really. And I want to thank the three panelists. I think we all, we didn't practice this. So, and I think it's, you know, more to come and better understand how this coronavirus is going to be overcome. And I'm obviously a believer in science, and especially practical science that we can use day to day. So, mahalo Nainoa and Bruce and the leadership for inviting us, really.
So this is Ben. You know, we just got a message here from Jenny Chow. You know, she's called in, and we were talking about her last meeting, and she's calling from Massachusetts. So it's about 15 minutes to midnight there. So she sent in a comment, and maybe I'll just read it. So mahalo to panelists for sharing your time and expertise to keep us all protected. I want to encourage all those who are likely candidates to work in dry dock to start preparing themselves by reinforcing their health and immunity. These plans seem to do an excellent job at avoiding anyone from being exposed to COVID-19. However, it is also advisable to have your body in top form to fight the virus. Right now, get enough rest, hydrate, feed your body nutritious foods, vitamin supplements if you can, and cut down on excesses that could bring any harm to your body. I have COVID-19. I am in my 7th week and at the tail end. I'm not 100% and I still have more recovery ahead of me. I'm not someone who should be at risk. There is a huge gap between mild symptoms and critical symptoms requiring a respirator. Recovering at home is not easy. It's nothing like a cold. Capital letters, nothing like a cold. I want you all to be safe and well and encourage you to take good care of your health now in preparation for dry dock work. Oh, thank you very much for the comment. Another question. What is the medical team's thoughts on how the arrivals will be led with our Polynesian brothers and sisters? Thousands of Tahitians close to each other celebrating Hokulea coming in. Boy, that's a hard question. That one to be determined. To be determined. I don't know really how to answer that at this point. In 1918, when that pandemic swine flu went around the world, it killed 10% of Tahiti's population in the span of like 2 to 3 months. 20% of Samoa got wiped out in like 2 to 3 months. I mean, that's nightmarish. When we go through Polynesia, when we take the canoe around the Pacific Rim, we're going to have to be very respectful of what is going on in each of our destination sites and work with those countries, representatives from those countries with our hosts as to what's medically as well as culturally proper. So yeah, I'm not certain how to answer that now. How will we plan canoe arrivals when we go through the South Pacific? We'll have to answer that later on. Another question here. Thank you so much. This was an extremely informative session. I have a couple questions. One, while younger people are at lower risk for complications and death based on the South Korean and other testing models, younger people seem more often to be asymptomatic carriers. How can that risk be minimized if people are carrying the virus but don't have symptoms?
Mask.
Kelly, maybe I give that to you to answer.
Yeah,
Because I don't know how.
I mean, the mask. We have to wear a mask and stay 6 feet apart as much as possible. The mask is more to like prevent you from giving it to somebody else as much as it's to prevent somebody else from giving it to you. Surgeons wear masks in the operating room not because they think they're going to get sick from the person they're operating on. They wear their mask in the operating room to prevent them from contaminating the person they're working on. That's going to be the same thing. The reason why you wear the mask isn't necessarily to protect yourself, but to protect everybody around you. Going to have to pay close attention to social distancing as much as possible where it can be done. I think that's basically, yeah.
Okay, the second part of this question, number two, have you considered a core group of people who live and work dry dock together, isolated from family and other work, so they are less likely to become infected and share with others at PVS or their families? That's an interesting thought. That's kind of way ahead of ourselves. Maybe
Well, I think that's what we had on that one slide with the graph that I showed with the 3 panels for self, for ohana, and for necessity. That's really what we're laying out there, is to try and determine what the individual's risk factors were. Not, I mean, to some extent for transmission, but I think it was more important for us to capture on some level what the risk would be if this individual actually contracted COVID. Like how consequential could it potentially be? And that has to do with what particular risk factors they have, as well as their living situation. And so it becomes really relevant. And that is why we're including that as part of that screen, is to ask about the living situation, and who would potentially be infected, or who could potentially be affected if you're infected. And I think that if we weigh that with your individual risk factors against what the necessity is for you to be physically present, then we can kind of have, it's at least a tool that we can use in some capacities in order to help us determine risk benefit for having somebody be physically present. So yes, those are very pertinent things that we are looking at.
I think also part of that question was a question about working in cells, possibly, where groups of people would only work with each other and not intermingle with other groups to keep the possibility of infection, to keep people from spreading one group to another, which is an idea that's been sort of bandied around a lot around, not necessarily with the Pacific Voyaging Society, but just in general around the world. And it's something that we will probably talk about, but not anything that we can, there's no decisions right now, but I think that's actually can be a decent idea.
Yeah, this is Marjorie. I think it's also really important to think about the idea that everybody is buying into this idea that we're all part of an effort to reduce the spread of other people, whether it's some of the leadership that we're worried about, or our family members or our other crewmates. If one person decides, well, I thought they were just kidding or whatever, I was totally convinced by Dr. Ben. But we all have to do our part, and living and working dry dock together, if we created those clusters, even if you created a cluster, you know, you still need to be mindful of what happens when you're somewhere else and exposed to somebody else. So that's actually one of the main purposes of this talk, was to give information and get everybody on the same page, but also this idea that we, even before coronavirus, we all have kuleana for our health, and we need to step up to that. And if being on the canoe is a motivator for that, great. Everybody has something that inspires them to move forward, but it is our responsibility. It's our kuleana. Sorry.
No, thank you for the comment. Okay, I think that's it.
Yep.
Finished 4 minutes early. So,
Nainoa,
with that,
say anything? Gotta
Your
Kevin,
microphone.
Okay.
unmute. There you go.
No, I'm like Bruce. I gotta take a walk. I'm thinking about this. It's a lot, but I mean, you guys are paving the way. It's a course. I mean, we made promises. We're gonna keep them, and there's good questions that we can't answer today, and I think it's clear that stuff is gonna change. But I do think it's a new world, and we're gonna have new rules, and we're gonna be smart about it. I think. Well, I'll end by saying this is really helpful to help me be able to feel that we can keep voyaging and keep it smart and keep it responsible and keep it caring and be everything we were yesterday in a new world. And in some ways, I think is what we learned from yesterday in terms of values and principles that you stand up on and you believe in. And today was a day where we exercised them. So just simply thank you. This is a really amazing new beginning. And frankly, I'm ready to go and start talking to people that start making up rules and say, should watch this video. And help them do what they got to do. There's 1,000 or maybe 10,000 or 1 million decisions that need to be made, and in our home, and they need to be good ones. And so, to some degree, I think what you put together, you 4 doctors, is not just for us. It's for all. It's much larger than that. So, thank you, and thank everybody for tuning in another 2 hours, and we're very grateful that you're taking the time to be part of the learning process, because we can't do this by ourselves. This next voyage will take thousands of people, and so and they all have to come home. Okay, take care, guys. Thank you. Aloha.
Hey, Nainoa, did you want to quickly remind everyone about what Friday's session is about right before we hop here?
Bruce and I are going to talk, and then we'll rethink what we're going to replace it with, and we'll try to let everybody know via whatever you do, email or whatever it is, and by tomorrow what the topic will be. But I haven't had a chance to talk to him, so I just want to be thoughtful and have that conversation. I'm going to meet with him tonight.
Okay, great. So folks, we're gonna send out the link with the recording and hopefully with that topic for Friday's session. Mahalo again to all of the panelists. If you haven't met our panelists already, you will eventually someday. Maybe you'll be wearing a mask and you'll be standing 6 feet apart lashing. But also, let's see. So yeah, if you're not getting emails yet again, please just let us know if you need to get subscribed onto this list that gets those updates and links and the invitations for the webinars. You can send that to info@pvshawaii.org as well. And the lovely Brandy will likely reply to you because she's awesome. At any rate, thank you all for hanging out with us this evening. And for those of you who are going into 1 o'clock in the morning, have a good night. And we'll see you all next time. Aloha.
Aloha.